Hi, I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I'm delighted to be speaking with my friend and colleague, Chris Koller, President of Milbank Memorial Fund. We're talking today about the report that has been produced by the Graham Center and supported by Milbank and the Physicians Foundation, the Primary Care Scorecard, the third that has been coming out in a series of scorecards. Chris, I'm delighted to have the opportunity to talk to you about the report.
Thanks, Ann. It's great to be with you.
Let me start us off. Once again, we found that there is this underinvestment in primary care, accounting for less than 5% of total cost of care spending. What impact do you think that has on the broader healthcare system?
Well, and the idea of the scorecard goes back to one of the recommendations from the 2021 National Academy of Science, Engineering, and Medicine report on implementing high quality primary care. And I had the privilege of serving on that committee, and we were really struck that to kind of use a quality management adage or quality improvement, we improve what we measure. And no one was really measuring system-wide, countrywide, kind of the health of primary care. And the report made recommendations in 5 areas. It's not by accident that we led with financing, both increasing the portion of dollars that go to primary care and changing the way that primary care is paid. And then including the fifth set of recommendations was this idea of a scorecard. This is now, as you note, the third year that we've put this out. We, the Milbank Memorial Fund, with support from the Physicians Foundation. And what we're documenting is that the the U.S. healthcare system is severely out of balance. And when I say out of balance, I mean it is disproportionately specialty care and institutionally oriented. And we're comparing that to high-performing health systems here in the United States. You at the Primary Care Collaborative have done a great job documenting what we're learning from the Accountable Care Organization projects at CMMI. We're pretty clear that those entities that succeed at in accountable care have a heavy primary care orientation. We'd actually like to understand better for all you researchers who are out there what portion of the ACO spend is going to primary care in these more successful places. And we know from high-performing healthcare systems that do well on population health and quality measures like staff model HMOs, Kaiser Permanente, and we know from other health systems, other countries, that they are just more primary care focused. Depending on how you count them, they've got primary care spend measures that are 50% to twice as much as what we do in the US. And the effects of that are that we are starving the capacity of the only part of our delivery system where the more we have, the longer people live. We can't say that about hospitals. We can't say that about pharmacy, but we can say that about primary care. And for the ones who are left, we're heaping more and more responsibilities on them. So, we found in the scorecard that's just come out that in 2022, primary care accounted for less than 5% of total US spending. Spending on Medicare has fallen to 3.4% of total Medicare spend. And Medicaid is only at 4.3. Commercial's a little bit higher than that, but it's just, so long as we're having that much of an unbalanced delivery system, we're not going to succeed on things that the new administration is talking about, making America healthy again, addressing the affordability issues that are haunting folks. Not only are we not paying primary care, the primary care sector enough, but we're paying them the wrong way. We look at the example of what the average reimbursement was in 2022 for a primary care visit. It's $259. That may sound like a lot, but if you compare that to gastroenterology, a single visit there generates revenue of $1,100, 1,092 in 2022 dollars. That's a difference of over threefold. No wonder clinicians are not interested in primary care if they can make that results in differences in physician income.
So I think what you're saying is it's the pricing, but it's also the method. So fee for service is also problematic. At the Primary Care Collaborative, many of you know we've been championing this notion of hybrid payment, which the NASM report recommended. Chris, can you describe a little bit more about what hybrid payment is and why you think, because you mentioned it in your report, why you think it could be a better way to pay?
Well, yes. When we say hybrid payment, it's hybrid means mixed. So the committee recommended a mix of fee for service and primary care. Some of that was based on evidence that there's some services, say vaccinations, where we just want primary care physicians to do a lot. And there's some services where we want that relationship. It doesn't necessarily have to come from a visit. It can come from a member of the primary care team. And so paying a portion in fee for service and a portion on a per patient basis allows primary care teams to develop the capacity to see people in the way people want to be seen. If it's a visit, great. If it's a televisit, that's great. If it's a consult with a nurse around what should I be doing, get everybody on the team involved in that rather than feeling like the only way the practice gets revenue is if they show up and if they see a practicing clinician, a primary care physician or a primary care nurse practitioner. There are lots of more advanced, more sophisticated ways you can think about this, but the main job is just to get physicians off of what they call the fee-for-service treadmill, allow the team to develop and provide care in ways that don't just involve the physician and the clinician. And I do want to call out the work that you and your colleagues have done at PCC at advancing this notion within accountable care organizations and also in legislative proposals. Thanks very much for your leadership.
I think this how much we pay is also a contributor to one of the other issues that your report raises, which is, we just don't have the workforce. Physicians are not going into primary care, but it turns out that although we're training more nurse practitioners and physician associates, their participation in primary care is also declining. So what do you think is contributing to this situation? And what does the report suggest we can do about it?
Well, it's all about the money. It's all about the Benjamins and what, so fewer and fewer physicians are going into primary care as a resident. I heard this quote, resident turned to their supervising physician, a primary care resident said, or rotation. It was a medical school student in rotation, said, why should I go into your specialty? You work harder than anyone else does and you get paid less. The scorecard documents that we are seeing a lower portion of physicians go into primary care. And the point that you made is really important. It just points back to the economic incentives that are in place. The end result, and this is sort of the bottom line, is that we're seeing more and more people who report not having access to a usual source of care, both for adults and for kids. And that's the best measure we have of, if you will, the access issue is when I got a problem, do I have someone that I can call who knows me, who I have a relationship with, who knows my history? And the number of people reporting that are fewer and fewer. And, for a 25-year-old kid, maybe I don't need that relationship. But for someone with chronic conditions, for someone who's getting older, for someone with kids who wants that relationship for their kids, that's a real problem. When I was on the committee, we talked about primary care as a relationship, an ongoing relationship with a team and a family. And that really is what we're looking for. And like public health practitioners say, we have to make the right choice, an ongoing relationship with a team, the easy choice. And we're not doing that. We're making it a harder choice all the time.
Well, and some don't have any choice at all.
Yeah.
They can't find a primary care clinician, or once they get in, it takes a long time, and then once you're in, you may not have the time that you need. And so
Yep.
our reflection is that policymakers in state capitals and here in Washington, D.C., are beginning to understand that there is a primary care access issue. And some beginning steps have been taken to address that. Where do you see bright spots? And what do you think are the most important things policymakers do to reverse what, is now 10-year trends?
We think that it took public policy to create this problem with primary care. It's going to take public policy to change it. We're not going to innovate our way out of this. We're not going to compete our way out of this. We have to change the rules of the environment. The NASEM committee is clear that it starts with Medicare. We're really heightened or are encouraged by some of the changes happening at the federal level, both in the executive branch and legislatively in the executive branch. The 2025 physician fee schedule actually has a new set of codes that can be billed. They're called advanced primary care management. It really is trying to bolt on this idea of a hybrid hybrid payment system that you talked about earlier into traditional Medicare's fee-for-service system, where clinicians will have the ability to bill codes every month that represent, if you will, a monthly payment, a hybrid payment. And those codes are risk adjusted. So the sicker the patient, the more the higher the fee is paid by Medicare. The patient actually has to consent and show that they're aware of this code being billed. And I think that's a great way to kind of reinforce that relationship. And I know you and I have talked about this kind of off camera. It's going to be really important to monitor the take-up of that. CMS has gone to great steps to make it easy to administer because that's some of the feedback that they had before. So they've reduced the documentation requirements. They made the dollar amounts sizable. We want to see that take up. We want to see that spread to Medicare Advantage plans. We want to see it spread to commercial and to Medicaid. And I look forward to working with PCC to make that happen. On the congressional side, Senator Cassie and Senator Whitehouse on the Senate Finance Committee advanced a great bill called the Pay for PCPs Act that directs Medicare to do hybrid payment. It gives discounts for or waives part of Part B cost sharing for patients who designate a certain physician or clinician as their primary care physician. And it has Medicare do some long-term work around the fee schedule. So we're really happy with that and hope that it advances. And, look, we as the fund don't lobby for particular bills, but we do want to note that these sorts of proposals are very consistent with what NASEM has proposed. At the state level, in a legislature, it's all small. One call is a problem, 2 calls is a crisis, and 3 calls is a law. And it's even shorter if the problem is happening to the legislature. And what we're seeing is that legislators themselves are experiencing this problem of primary care access, what you talked before. And so we're seeing more bills pop up trying to address that. I think the bills could be more comprehensive. I think there's work to be done by Milbank and PCC and other entities to make sure that those bills are not just kind of window dressing, but really get at how does Medicaid pay for primary care? What is your commercial health insurance regulator doing to get health insurers to spend more money on primary care? There's lots of opportunities at the state level to advance these efforts. We're starting to see the wake up, but frankly, the policies could be more comprehensive.
Well, it sounds like you also think that we need to have multiple bites at this apple. Having the administration get into the mix with reform of the fee schedule. They've started to do that. I'm calling APCM the mini hybrid because it's not as comprehensive, but it's a start in that direction. And Congress themselves is talking about Medicare payment reform. And so how does hybrid payment for primary care fit into that larger conversation? And then the states. Others would argue that we need communities to be clear about the kind of primary care that they want. And so, with any movement. And I think that this actually needs to be a movement. If we're going to move our healthcare system toward a system that is focused on wellness and health, as opposed to, providing sick care services, which obviously it needs to do, but that should not be a primary focus. We need both kinds of services, but we need, the incentives directed towards wellness and health, and that's not currently our system. So, I'd agree with you about the multi-prong approach.
Well, yeah, and you do call them a movement, and I think that's important. I mean, I didn't even mention that a couple of weeks ago we had the privilege of meeting with 8 Medicaid agencies that are participating in CMMI's Making Care Primary payment demonstration. That's a 10-year project to do the sorts of hybrid payments that you were talking about. It's really exciting to see how hard those states are working to make it happen. They're thinking about how they can get commercial payers on board so that you're sending consistent signals. And then last week, the National Association of Community Health Centers had all their community health centers in town in Washington. And when they are going up there to talk about health center funding, they're not just talking about health center funding. They're talking about primary care funding. They're talking about raising the portion of spending that goes to primary care. And I think that's really important for folks listening here who are advocating on behalf of primary care to think about to build on the successes of the community health center movement. This is not an either or. If we don't improve the way we pay for primary care and for the way we train clinicians, there's going to be no providers left for community health centers or for the health systems that want those primary care docs. So, it is, we're starting to see people get the connections about the centrality of primary care for this work.
Could not agree more. And for those of you who have ever had a health issue, or a friend or family member has, you know that if you don't get the care that you need early on, it's so much more complicated and more costly. And too many Americans have the front door of the healthcare system either, shut or very difficult to open. And then, they have all of these downstream unfortunate effects. So it is a really important issue for our country. Chris, any last thoughts as we wind up this conversation today?
I think anyone listening to this discussion ought to I would encourage them to look for ways that they can contribute to this work, whether it is at the community level, the local level with their community health centers, at the state level, helping to educate legislators and policymakers about the centrality of this work, at their own kind of personal level with just how do they seek care and where are the points where they're going in, and then at the federal level. I think there is, this is, primary care is really a bipartisan issue. And of course, anyone who's looking at the scorecard and thinking about this stuff, you got to join PCC. You got to get the information. That's the place to get the information about where you can make the most difference. I do want to note that accompanying our scorecard is this dashboard. It's at milbank.org. The Graham Center was very helpful in putting it together. That's got state-specific information for a lot of these measures that folks can use to understand what's going on in their state. We've worked really hard to give more interactive capacity to the dashboard so that you can call up comparisons between your state and other states, and generate information and graphs that are useful for local discussions. So I encourage people not only to look at the scorecard, but to look at the dashboard behind it.
Terrific. Well, we're excited that this third tranche of the report is out. I think it's going to be incredibly useful for all of us who are trying to educate decision makers about the importance of primary care. And, you get such incredible value if you increase the spend. Well, thanks so much, Chris. It's been a delight.